I have the honor of introducing our speakers for this evening. These are two members of our board of directors, and of course, they're DSMIG members as well. Dr. Peter Bulova is a professor of medicine and co-director of the McGee Center for Women with Disabilities, and he is also the director of the University of Pittsburgh Adult Down Syndrome Center. And then I'd also like to introduce Dr. Mary Stevens, who is the medical director of the Jefferson Continuing Care Program and an associate professor of family and community medicine. So without further ado, we're going to get started with tonight's program.
Hi, we want to welcome you to Down Syndrome 101 and 202. So get ready for a wild ride. We have no official disclosures, although Peter and I are both on the board of DSMIG USA. This is my unofficial disclosure. This is my daughter, Callie, who is now 10 and a half and has Down syndrome. And I hope you approach learning from this lecture with the same enthusiasm that Callie approaches life in this picture. Although know that she's just like any other kid and she is not that happy all the time. Here are our objectives. We're going to talk about common things, but help you take a more nuanced approach to individuals with Down syndrome. We're going to focus on wellness, and we're going to identify some resources to help it help make it easier for you to provide care. So your medical student looks ahead at your schedule, and there are 3 patients on it the next day who have Down syndrome. Yipes, the student panics. All he can remember about Down syndrome from the boards is a risk of congenital heart disease and leukemia. They want to learn from you. So here's a quick way to get them jump-started. Just go ahead and share our lecture. So it's really important to set the atmosphere for care for all of our patients. But I think there's a few extra things to keep in mind when taking care of individuals with Down syndrome. So in general, we should be thinking about the use of person first language. So an adult with Down syndrome versus he has Downs, or a Down syndrome adult. There's been a real shift in the literature and in practice, and certainly in the advocacy community, to move from using the term mental retardation to using cognitive or intellectual disability. And we'll talk about that more later as it relates to individuals with Down syndrome. Special Olympics, which many of our patients with DS participate in, developed a focus a few years ago on spreading the word to end the word. So take a look at the graphic, and the bottom line is no. All right, so a little background. We all like our little epi slide. So we think the occurrence of Down syndrome is 1 in 1,000 live births, although some estimates shift it more to 1 in 600 to 750. It results from an extra copy of the 21st chromosome and can be due to duplication, translocation, or a mosaic form. There's really not many differences phenotypically when we look at individuals who have these different type of chromosomal abnormalities. So back in the 1970s, the median age of death was less than 10 years of age for someone with Down syndrome. Now we know that median age is all the way up to the 50s. So we've made a huge amount of progress, but it also means that there's a lot of adult medical providers who just don't have the skills that they need to take care of individuals with DS. But we're glad you're here and learning with us. Leading causes of death in individuals with Down syndrome are respiratory and related to cardiovascular disease in individuals with Down syndrome. This isn't atherosclerotic changes, but congenital heart disease. And it's really important to note that about 70% of individuals with Down syndrome do have a diagnosis of dementia at the time of their death.
Okay, I'd like to pick up from here, and this is one of my major part of this talk is to go over what are the common medical issues that you will encounter when you see adults with Down syndrome. And often you will see a slide such as this one, which I think is a little too much for anybody. And when I look at this slide, I always think about how lucky I am to take care of adults. As most of these things are seen in kids, I think we see most of the complications in the age group of 0 to 5. So I think our job treating adults is a lot easier, and you shouldn't have to worry about all of these things here. So we're going to focus on a couple of them that are much more common in adults. Will make you so that you'll be able to look at what are the things that are most going to impact people's care that you're seeing. So I did put up the one congenital one, which is the cardiac issues, because about half of our patients have had some sort of congenital cardiac abnormality. These are so much easier to treat now than they were decades ago. Our patients are doing extremely well once many of these have been repaired. Here's my graphic here, a triangle. And the reason I put this up is this is the focus of many issues that we see is the small mid face. The major issues with this, often people have a very crowded oropharynx, so sleep apnea is extremely common. And we'll see severe sleep apnea 30 to 50%. There's numbers as high as 70%, 80%, 90% of people that have some sleep apnea. And I think that we find that it is clinically significant in a very large number of patients. So something always to keep in mind. And you'll hear a lot about this during the next 45 minutes. Decreased hearing is very common. It's another one that we screen for. It can present in a myriad of ways. So someone who slowly has decreased hearing may become less involved in activities. They might seem to have a decline in skills, and you might see someone given a diagnosis of dementia when all that was happening is decline in hearing. We find the same thing with the decline in vision, which is another one that's common in adults. Again, with that mid-face, sinusitis is quite common. We do a lot of treatment of chronic sinusitis, and most of our patients do have pretty significant cerumen impaction. I send a lot of people over to ENT to have all of that removed. And then I wanted to thank Mary for our picture of Callie here. This was her with her, looks like a whole setup for sleep study to look for obstructive sleep apnea, which again, very common and something we want you to keep in the back of your mind with almost every patient that you see. Before I get to the next organ system, I want to give you a quick case. This is a 22-year-old patient with Down syndrome who presents with new behavior changes, 15-pound weight gain, and is tired all the time. What is the most likely diagnosis? And there are three choices here: dementia, early menopause, and hypothyroidism. And I'll tell you, we do have many people that come to Down syndrome centers at very young ages for rule out dementia. So you will not see dementia in someone who is 22 years old. Early menopause is definitely something that we see in our patients, but never this young. So that the answer for this case is going to be hypothyroidism, which is very common and definitely can present with all the same kinds of findings that you'll see in patients without Down syndrome. So the common ones that you'll see: hypothyroidism, you'll see a very large range. I think in my patients it's probably about 40%, and that's what we've heard in the literature. I think Dr. Chacoin's study was also around 40% for patients with hypothyroidism. So something that with the new guidelines that came out from the Global Down Syndrome adult guidelines, the idea was to screen for hypothyroidism every 1 to 2 years, and that's after age 21 because it is such a common condition and can present in so many different ways. Diabetes is also more common in adults with Down syndrome, and it starts being more common probably at about 21. So the guidelines for diabetes is to screen for this at least every 3 years after age 21 for people that have a BMI over 30. And for age 30 and over, also screen every 3 years, even if your BMI is below 30. So good lab work to keep in mind when you're seeing your patients. It's another case for you before we get to another organ system. This is a patient who I saw, a 30-year-old female who didn't want to leave the house. She had loose stools for years, was chronically underweight, didn't want to go out because she was always afraid she wouldn't be able to find a bathroom. And her physician told her that that's just the Down syndrome. This is something that, doesn't have any other bearing except for people with Down syndrome can have things like this. So my question for you, do you need to investigate this further? Or no, there are several medical problems that can present this way, so maybe you should investigate it. And of course, in this case, this patient had celiac disease. Celiac disease, much more common in adults with Down syndrome, can again present in a myriad of ways, everything from constipation, diarrhea, changes after eating, but also it can just be a decline in skills, changes in energy, all kinds of ways that this can present. So do keep this in the back of your mind in someone that has a major change. For the two other major GI issues that I would like to call attention to, difficulty swallowing is quite common. We see many adults with aspiration pneumonia, people that eat very fast or just have difficulty swallowing. So we're very aggressive in treating people that are having lots of issues with aspiration. We try to get speech pathology involved to help with anything we can do to help with that. Reflux, again, really common and quite a masquerader. It's one that can present in so many different ways. We see it quite commonly in our adults. And it can present again with a decline in skills. It can present with weight loss, but often people won't tell you that, yes, this is all because they notice that the pain, but you look for changes, especially after eating certain foods. You'll hear much more about these from Mary going forward. And so I'll leave most of the issues about dementia, but again, this is something we screen for after age 40, and this is also in the global guidelines. Seizures are something that is definitely more common and something that also can be associated with dementia if it happens in an older individual. Mary will bring you back.
All right, thanks, Peter. So one of the things that we know is that most individuals with Down syndrome, or all individuals perhaps, have some degree of intellectual disability. It can really range from mild to severe, but really keep in mind to focus on the individual in front of you. What are their particular learning strengths? Where are areas they're a little bit more challenged? Some people think that people with Down syndrome may have photographic memories. They may have really strong visual learning skills. So you want to know your patient and present information to them in a way to allow them to retain it and use it. So again, I think one of the points we want to make is when you're caring for an adult with Down syndrome, you're caring for an adult, and please speak with them directly, gauge them in motivational interviewing. Certainly caregivers, family has to be involved, but don't forget the patient in front of you and all they can do and all they bring to the encounter. All right, so cases are going to get a little bit harder now. We know one of the concerns of clinicians caring for individuals with Down syndrome is this dementia. So we're going to talk a little bit about some ways that Alzheimer's may look different in individuals with DS. Again, we're going to sort of reinforce those common comorbid conditions that you really need to be on the lookout for, and then talk about the treatment options. So a 55-year-old male with Down syndrome comes to your office. He had seizures as a child, but none for years. He has well-controlled type 2 diabetes. He's had his aortic valve placed years ago and his hip replaced. Medication list is actually pretty short. Just metformin, so an oral agent to treat diabetes, and warfarin, so an anticoagulant due to his artificial heart valve. His sister is his primary caretaker, and she's lived with him for a number of years. One of the things we have to be on the lookout for is Many of our adults with Down syndrome may transition from living with parents to siblings. And so you really want to find out, does the caregiver know this individual's baseline? So their concerns when they came in were concerns for OCD-like symptoms, an overall functional decline, and maybe some memory loss and increased self-talk. So self-talk, so come on, you know, we all do it. However, most individuals stop talking out loud by the ages of 5 to 6, but it is more common for individuals with Down syndrome to continue sharing their thoughts out loud. This can be disconcerting for folks around them. Overall, it's really probably a good thing, helps process thoughts and feelings, can be motivating. So our general teaching guideline, and one I've stolen from Dr. Chacoigne's McGuire, is self-talk shouldn't necessarily land you on an antipsychotic by any means. It's different than a hallucination or a delusion, but it is important for caregivers to pay attention to the tone and content to really get to the bottom of what's going on with the patient. We do know that depression, anxiety, and OCD are more common in our individuals with DS, and self-talk may give you a clue to this. So why is there this connection between Down syndrome and Alzheimer's? We think it's related to mutations in the APP gene on chromosome 21. We know that the pathology of Alzheimer's is present in the brains of most adults with Down syndrome, probably by the age of 40, but not all patients develop clinical disease, and that's really important to remember. And to Peter's point earlier, it is extremely rare to occur before the age of 40. So please, if somebody comes in with that diagnosis, step back, take your history, look at the prior evaluation, and really see where you are. So what are some of the unique characteristics in our individuals with DS? So change in gait may be an early marker of cognitive decline. Now, again, you may have to sort out if the individual is having problems navigating the stairs. Is it related to change in vision, which is common throughout the lifespan? Is it because they have osteoarthritis? So break it down, but really try to get at, is there a change in gait? Some specific things to look for are challenges with initiating walking, difficulty making turns, shuffling, and then the fear and avoidance of obstacles. So new onset seizures are also something that we see to mark the onset of dementia in individuals with DS. Some literature suggests childhood seizures may be protective or in no way related to future risk of dementia. Incontinence, more common, but other things cause incontinence, including constipation, which is something, if you take care of a lot of people with Down syndrome, you are always thinking about and talking about ways to manage. And don't forget, common things are common, so make sure you exclude urinary tract infection. Really, we want to look at overall decline in both occupational and social functioning and what's different. So when I'm talking to patients and families in my office, I typically talk about, so tell me what a usual day is like. What was a day or a week a year ago? And then paying attention to changes in mood and behavior. So we talked a little bit before that mental health issues like depression and anxiety may be more common and likely are in our individuals with DS, but we really have to pay attention here and see if they are co-occurring in our individuals with suspected dementia. As we get to treatment later on, cut to the chase, there's really not great treatment options. for Alzheimer's and individuals with dementia. So let's focus on what we can do. And so treating depression, anxiety may really do a lot to improve the quality of life of individuals, and perhaps slow down that rate of cognitive decline as they continue to interact with the world around them. We know, although there's a little bit of good news on the horizon, it's hard to gauge, does the individual with Down syndrome have depression or anxiety? Our standard PHQ-9 and GAD-7 are really not geared towards our individuals with intellectual disability, but there is a tool that's being developed that may allow us to have a standard tool with which to evaluate our patients. So we think that dementia may be worse in females than males, and this may be related to estrogen deficiency, the earlier menopause that Peter mentioned. Certainly menopause is when we will often start to see that decline. Unfortunately, what we haven't found is that replacing the estrogen makes a difference. Overall, in individuals with Down syndrome, while we do feel that it's much more likely to be of earlier onset, we have a hard time answering the question, is it more rapidly progressive? Lots of debate in this area and conflicting evidence, and it may be that we just diagnose it later because we miss stages of mild cognitive impairment. Early signs may manifest themselves as more apathy or social withdrawal, although disinhibition is another hallmark. Starting to see loss of executive functions. And again, this is really where it's so important to compare the individual to their own baseline. Later, we can see agitation, hyperactivity versus super slowness, and delusions and hallucinations can occur as they can in others with dementia, but we really want to make sure we're not confusing self-talk with delusions or hallucinations. So there is a screening tool to help us assess individuals. There's actually a couple, but I'm going to focus on the one used in the global guidelines. So the NTG, Early Detection Screen for Dementia, was adapted from another agent. We now know, or as the guidelines suggest, we should begin screening individuals at age 40. There is a comprehensive instruction book that comes with the screen, but there's really important signal items to pay attention to. You can download it, it's free, but I think if you don't have it readily available and you're trying to help your student learn what questions to ask your patient with Down syndrome about, really focus on things like these unexpected problems with memory, getting lost or major changes in gait, new seizures, confusion in familiar situations, and then personality change. But remember, over and over, when you're evaluating a patient, don't lose the focus on the differential diagnosis. And while our patient came in with a pretty clean medication list, some of the older patients with DS that we care for come in with a very extensive medication list. And so, look at your Beers list. Think about what medications could be causing anticholinergic side effects. Really see, is there anything there that you can clean up? So not great news on pharmacologic therapy, but there is a lot that we can do to improve the quality of life for both the patient and the caregiver. So treating depression and anxiety is really important. Screening for those common things, treating hypothyroidism in the scheme of it's not a big deal. That may make a big difference. If you're seeing an individual who may not be a great eater, well, or maybe they're on metformin, think about checking that B12 and folate level. So pull in all your comprehensive medical knowledge and really take a deep look at the patient. I do use the Guide to Mental Wellness by Dr. Chacoin and McGuire in my office. Our Down Syndrome Association has donated copies for our families. There's also great handouts and booklets from NDSS and NDSC. And I think just like anytime we give patients big news, they need time to digest it. And sending them home with well-written materials is an important part of the process. Like I said, the treatment reviews, here's the evidence. The last Cochrane review is in 2015, and evidence is slim that anything makes a difference. I don't think any of us who care for a lot of individuals with DS are jumping on a simvastatin bandwagon, but in this study, that was the only thing that popped out as positive. Other things to think about, again, setting the environment for care. So some resources I like are listed on the slide, like Jenny's diary. Helps the individual understand what they're going through. But other things to really think about: what's the health of their caregivers? What support do they need? And for the individual with Down syndrome, really trying to make the balance of the right level of activity. So if they work, is it time to think about retirement? If they go to a day program every day and it's a really long day and they're not getting their sleep, is it time to think about shifting gears and finding a different level of activity? So with our patient, it took lots of people and a village, and we were really able to improve his functional status. And that was a long and deep case, so I am turning it over.
Okay. All right, and we'll start out with a new case and a very, very different topic, but one that I think you're all quite familiar with at this time. This is a case of a patient with a cough. Your 50-year-old patient with a medical history of reflux, pneumonia, and arthritis presents for a video visit. During your discussion, you notice that she has a slight intermittent cough. You ask about her cough, and her reply is, "I have allergies, and they always get worse around this time of year. Cough began 3 days ago." She admits that she does feel somewhat short of breath with exertion and is attributing that to her known allergies. She has no feverishness, no chills, headache, or gastrointestinal symptoms. She denies nasal congestion, coryza, and itchy eyes. She relates that she has been staying in except for trips with staff from her group home. So of course, what I am getting at is what we've been seeing with anyone who comes in with a cough, and the things that we're looking at is, what do we do about COVID? And this is very important for this population. That's why we're including it in this Down Syndrome 101 presentation, because it is something that has really taken a huge role in the care for our patients. So why are people with Down syndrome at higher risk? Seems to be several things. They're in group homes, and people with intellectual and developmental disabilities are often in close proximity to one another and to their support staff. So being indoors with other people tends to be definitely a high-risk place. These shared living environments might facilitate the introduction and spread of COVID. We do see a higher rate of chronic health issues, poor health status, especially in our adults. And I think you'll see that the age where COVID is quite serious is much lower in people with Down syndrome than it is in those without Down syndrome. For many conditions, we do see higher rates of death from flu and pneumonia in people with Down syndrome. So it does seem to make sense that we would see higher rates of morbidity and mortality from COVID. This was a study I really liked. This was a correspondence relating to another study, the trisomy 21 Research Society survey, which they looked over about 800 cases. Of those 800, 400 had been hospitalized, and of those 14% died, which was much higher than in the general population, those without Down syndrome. What I thought was nice about this, the lessons that we have learned over the past, at least a year, and I'll put this up for the next slide here. The number of COVID cases dropped substantially in people with Down syndrome after that first wave. So there's very high rates back in March, all the way through May, and then they seem to really drop off. And what the suggestions were from that article is maybe this is because of some of the strengths of our patients. They have constancy, tenacity, commitment to tasks. This is a group that if you ask them to wear masks, if you ask them to social distance, very responsible group. Individuals might be teaching a quiet lesson to the rest of the population was the take home from this article. The persistency, things like hygiene showed by people with Down syndrome helps them to learn and adopt to recommended protective measures against this infection. This was one of the first studies that came out of Italy, and they looked at everyone that passed away from Down syndrome and compared those with Down syndrome and those without. And I wanted to give you just a couple take-home points from this study that I think you can use going forward. So of the 16 people with Down syndrome who died, their average age was 52. And if you look at those without Down syndrome, the average age was 78. So we're looking at a much younger population at very high risk. Of those, 30% had a bacterial superinfection, whereas less in those without Down syndrome. And one of my take homes from that is to really think about it as the major superinfection was pneumococcal pneumonia. This is a group that we can think about, would they benefit from Pneumovax? Of those, 100% died of acute respiratory distress syndrome, just about the same in those without Down syndrome. So you're looking at the same illness, you're looking for the same things that will cause mortality, focus on the respiratory issues. So how do you do that? Routine is key, social distancing, wearing masks, washing hands, and of course, vaccination. And they've worked very hard in many different states to be sure that Down syndrome is listed as one of the high risk reasons to get vaccinated. So I found that it is easy to get vaccinated if you have Down syndrome in just about any area. So this is something we have been speaking about with all of our families, group homes, and it's made a tremendous difference in our community. Question that I get asked often is, how much do masks help? Do they make a difference? Because many people don't like to wear them, which is quite understandable, but boy, they really do make a difference. This was one study from Thailand back in November that showed a 70% reduced risk of becoming infected compared to those who didn't wear masks during high-risk exposures. Wearing the mask sometimes instead of all the time didn't lower the risk. So you really have to be very good about wearing the mask for it to be effective. Maintaining a 1 meter distance, having close contact for less than 15 minutes, frequent hand washing, those were all associated with lower risk. Those are things to think about. As I said, social distancing, trying to stay away from by more than 1 meter, short contact time, less than 15 minutes, and again, frequent hand washing, and all have been shown to be helpful. We have seen that this has caused a lot of downstream problems these past 16 months. There are so many pitfalls of isolation, especially for adults with Down syndrome. And we are seeing changes in people. We are seeing that people do have some long-term behavioral issues and health issues related to the amount of isolation that they've been experiencing. We see a lot of behavioral changes, sometimes regression and loss of skills, significant increase in self-talk. We look for rapid shifts in mood and tearfulness. Disruptive behaviors or angry reactions that weren't present before may all be related to this new episode, issues with isolation. So what can you do about it? Here are a few things that you can think about doing. It's a long list, it's a busy slide, but I wanted you to have some take homes from this of what can you do and still be able to maintain real safe practices. So as much as you can maintain routine and maintain structure, extremely helpful for adults with Down syndrome. If you have visual schedules, checklists, very helpful. Finding ways to stay connected, video chats, texting, phone calls, letters, anything that's going to keep people connected. Making a list of activities that are allowed. Overall, people with Down syndrome can be very influenced by the emotions of others. So be very careful and mindful of your own emotions as you might be impacting someone that you're with that has Down syndrome. They can be quite affected. This is a group that we think of as having a very high emotional intelligence, a group of people that in general really can notice how people are feeling. And psychologists, therapists, other professionals, especially someone that knew the person with Down syndrome before they've had the changes, can be helpful. So thinking about other immunizations, I talked about the pneumococcal vaccine, definitely something to think about, especially in people with low white cell counts, anyone with chronic lung disease. Don't forget about these other comorbidities. And then there's some other age-based recommendations too. Okay, and now I'm going to bring it back over to Mary.
Okay, so we're going to end on a strong note here, really positive. So one of the things that we really want to help the patients we take care of with Down syndrome, actually all of our patients, is to stay physically active, to be strong. And for many of our patients, Special Olympics is a great venue. It's free to participate. There's groupings based on age, and there's year-round sports. So it's not just the physicality of it, it's the ability to develop friendships and leadership skills. We know in general, folks with intellectual disability are characterized as quote unquote an extremely unfit population, and giving this even small increases in fitness can really change the trajectory of patient outcomes. So it can be a little daunting because most of us have never been taught to do a pre-participation exam to clear somebody to participate in Special Olympics. So we're giving you a link to a resource. This is a module I got to develop with some folks from SUNY, and you can access it. And if you haven't done much pre-par exams, it may be a big help. So the biggest thing that makes people nervous about clearing folks with Down syndrome for participation in Special Olympics or other physical activities is the risk of atlantoaxial instability. So this is assessment movement of the first and second cervical vertebrae that can cause damage to the spinal cord. We think radiographically about 10 to 30% of individuals with Down syndrome have evidence of it, but clinically it usually presents in individuals that are less than 10. Although don't forget about it, because we've all taken care of teenagers and 20-somethings who have had symptomatic atlantoaxial instability. So contributing factors, abnormal bony architecture may occur. We know about the low muscle tone in individuals with DS and general ligamentous laxity, and weakened ligaments all play a role. But for those of you who've done Special Olympics pre-part exams in the past, you remember these cervical x-rays you had to order. Well, what we know now is that screening x-rays are not really predictive of symptomatic atlantoaxial instability, and they've sidelined a lot of athletes unnecessarily. So although the uptake is still ongoing throughout the US, In most states, screening x-rays no longer need to be obtained prior to high-risk activities, and there's really no indication for baseline x-rays. If families have an interest, if you have clinical concerns, well, that's a different story. But if you are doing them, know they are not reliable prior to the age of 3, and don't routinely repeat them. But we know atlantoaxial instability is real. And there is a nice section in the global guidelines that discuss this. So you need to know what it looks like. And once again, history and physical really come into play here. The newer Special Olympics forms cue you to ask these questions, which is always great. Things to look for: easy fatigability, difficulty in walking, abnormal gait or incoordination. So again, these are differences from the patient's baseline. Certainly, we need to pay attention to reports of pain, but know that many of our patients with DS are not complainers. So look for these other physical exam signs that are so important. The general recommendation as we care for adults with DS is to screen annually or thereabouts by history and physical for red flag symptoms of AAI.
Okay, let me just go over some of our take-home points here. And I think that last slide with the red flag symptoms is really helpful. So it's a good one to remember. This is another one. I hope if you remember any one slide, this one has a lot of what we already talked about. So first, consider medical and psychiatric causes before making a diagnosis of dementia. And again, we're talking about the age of 40 and later is when you should really have that higher on your differential, and much lower before the age of 40. And we often do see people that have behavioral changes when there's a medical issue. And sometimes what looks like a decline in skills from something which you might think would be dementia might actually be a psychiatric cause. So these are things to really run through your differential before making that kind of a definitive diagnosis. The medical issues that we've talked about today that are so common, we want you to consider. So in terms of mental health, think about depression, think about anxiety. For our GI, think about celiac, think about constipation. Respiratory obstructive sleep apnea can present in so many ways. And of course, thyroid disease, because it is such a common thing that we see. So when we talked about the new global guidelines, the 3 things that to keep in mind for screening would be hypothyroidism, and this is after age 21 to screen every 1 to 2 years. Diabetes, between 21 and 30 if someone has a BMI greater than 30, and we're screening at least no more than 3 years. And after age 30, screen everybody for diabetes, again, at least once every 3 years or so. Talked about COVID. COVID is more severe in adults with Down syndrome, but it does present similarly in those without Down syndrome. I do want you to keep in mind that some people will present in other ways. So someone with COVID might present with mental status changes, and that might be their first presentation, but the morbidity and mortality is the same. That's really respiratory. And then finally here, screening x-rays for atlantoaxial instability no longer need to be obtained prior to high-risk activities. But go back one slide if you get a chance to think about those high-risk red flag things, which may make you want to investigate this further. Okay. Thank you so much for listening. It has been such a privilege to be able to give this inaugural talk. And the next part we'll have for you is going to be questions.
Thank you.
All right. I think that we have a few minutes for questions, and I'm going to let Peter and Mary, I'm going to let you take.
Good evening, and thanks everybody. So feel free to throw some questions in the chat. Peter, do you want me to take a stab at that first question about the link between physical and mental health?
Sure, sounds good.
All right, so so Brian Chicoine, I think you taught me so much about this, but Thank you for asking the question. So one of the things that I really make myself stop and think and remember is that kind of behavior, change in mood, it's a form of communication. And let's make sure we're excluding medical conditions, whether it's painful folliculitis or hidradenitis, whether it's the wax in the ears that Peter mentioned. And sometimes we have to really kind of negotiate with families and really make sure people understand that depression and anxiety is real and it's a real medical condition. There's many ways to approach it therapeutically, but sometimes we have to look at meds to increase the serotonin. I think many of us tend to start with sertraline or escitalopram, tend to start at low doses. These medicines, I know for sure the sertraline you can find it in liquid formulation, which is important for us to think about because not all the patients we take care of swallow pills. Peter, you want to take the next one?
Yeah, sure. So there are a couple of questions. These are great questions about when should we do audiology screening for changes in hearing and when should we do vision screening. There's a couple really common ophthalmologic issues, and the two most common were mentioned in the question, and they are cataracts. Cataracts can occur at a very early age in people with Down syndrome. It can be in their 20s and 30s, whereas it tends to be something so much later in people without Down syndrome. And keratoconus is a change in the shape of the cornea, and it's also something that is much more common in adults with Down syndrome. We don't have great data about how often to screen for these. From what I've seen, it's every 2 years for audiology and for vision. If you can do it every year, that's great. And then there's a question about experience with monoclonal antibodies for COVID. There is no published data on monoclonal antibodies for people with Down syndrome. In the Down syndrome medical interest group, we've passed around a couple of questions about this, and there's been some individual anecdotal evidence that it has been helpful. So I do recommend it for my patients if they do test positive for COVID.
Just to touch back on the screening question, I talk about this a lot in my office, that all of us are still, at least I hope, are still learning and growing and acquiring new skills. So although perhaps an individual with Down syndrome really struggled with getting their blood drawn or their eye exam or going to the audiologist, it doesn't mean they can't acquire that skill. So in our office, we practice blood draws a lot because it's so important to get that TSH. Same thing, practicing getting folks to the eye doctor. We kind of have our little unofficial pick list of docs and offices that respond well to our patients and build upon those successes. For the sleep studies we mentioned, many patients can do a home sleep study. It all is insurance dependent. We think that home sleep studies maybe underestimate the degree of sleep apnea by a stage. So severe sleep apnea might present as moderate, but there's a lot less attaching things to do and people can get through the test. In our sleep lab, we've really worked with their team to make the environment positive for our patients, to allow a caregiver or trusted family member to be there with the patient. And again, like cherry picking that right tech who is going to make our individuals feel calm and confident and be able to get all that done.
Okay, I want to thank Tom Stevens for a great question, which if we could plan a question for this talk, this would be it. So there are going to be some follow-up presentations. One of them is going to be on the global guidelines, so that'll be coming up soon. And Marilyn Bull is updating the pediatric guidelines. There's a really nice published guideline for kids, which came out in 2011. And the update is coming soon. Dr. Bull is going to be giving a presentation much like the one we're giving right now. In terms of what other resources do you use, there are a couple really great articles that just nice review articles, and those are on the Down Syndrome Medical Interest Group website. So if you look under care for adults, there's a list of several different studies, or actually just review articles for that.
Want to thank Mr. Dr. Tom Stevens for jumping in there from the other room of our house. Full disclosure, you know, other things that we think about, so cancer screening guidelines, you know, a lot of us in primary care are used to our quality report cards now. So you have to think about the age ranges and the life expectancy of our individuals with Down syndrome and when we might need to adjust that. Brian Chicoine and others are trying to get us good data so we know the actual risks. There may be a lower risk of breast cancer, so perhaps, you know, just screening every 2 years with mammography, which is one of the options in the guidelines, is a reasonable choice to make. Again, I think taking a very patient-centered approach. For colon cancer screening, you know, we've talked today a couple of times about the risk our individuals have from respiratory infections and, you know, maybe an increased risk of anesthesia complications related to hypotonia and reflux. So in this patient population, I'll offer, you know, the range of options, but perhaps focus more on things like FIT testing or other non-invasive ways to screen individuals for colon cancer.
The only thing I wanted to add, I was looking at when one of Mary's first slides was talking about you have a student with you and you're going to see people with Down syndrome. So I just wanted to mention a couple things that I say. We have a lot of, I don't know if we have any genetic counseling students that are on this call. Hopefully some will watch it if we have medical students. Some of the things that I always make sure to talk about is, one would be, I think it's so interesting about how the same genotype, that same 16,000 base pair change that we see, it's really that the genotype is the same, but the phenotype can be incredibly different. And it's really hard to predict that. And it makes it very hard to counsel. I think that we're seeing that in general, people with Down syndrome are doing very well. As Mary said, are living now with a median age into their 50s. And that definitely was not the case before. And if you're counseling families who are going to have a child with Down syndrome, the first thing to say is congratulations. I think there's a lot of talk about that's how you should always start your conversation.
I'm going to add to that, and very thankful for the geneticists who saw us after we had Callie, who talked about great joy and great expectations. I do a lot of work at Jefferson around care for patients with disabilities, and we hear the voice of the patient. And one of our patients said, you know, the hardest thing for me to recover from in terms of my spinal cord injury was not my paralysis, but the low expectations I had of myself and those around me. So keep those expectations high. Good question from Emily Dow about recommendations for screening for cervical cancer. So, you know, some controversy here. There's no guideline that bases recommendation for cervical cancer based on sexual activity. So I think we have to try. If my patients are undergoing anesthesia for other reasons, I will certainly try to tag team GYN in there to do that, or family docs or med-peds docs who have OR privileges to go in and do that. A lot of us will do blind PAPs in our office. So doing a pap smear without a speculum, and I've had many patients tolerate that. Recent update came out that looks like there's going to be a shift in cervical cancer screening guidelines to push testing back till age 25, and that primary screening via HPV status is equal to or superior than cytology. And I think that's going to be a lot easier because that's a simple swab you send off. Yes, there is probably a lower risk for HPV. And when we talk about immunizations in our patient population, I fully support HPV vaccination for those within the right age range to be immunized.
Yeah, we have a center here in Pittsburgh just for doing a lot of gynecologic care for people with both intellectual and physical disabilities. I think we have to be careful in this. I completely agree that risks are quite low for cancer, and we try in any case that we can to avoid general anesthesia just for the reason of doing a pap smear. That being said, our patients sometimes don't always tell us what's going on, and we're always keeping in the back of our mind that we have the risk for abuse in some of our patients. So we want to make sure that at least we have the discussion with family members. It's really nice to have at least a try with an OBGYN or someone that's experienced in working with people with intellectual disabilities.
Well, thank you so much, Peter and Mary, for your wonderful presentations. And